Australia is regarded as one of the safest places for a woman to give birth, with morbidity and mortality rates some of the lowest in comparison to the world. Unfortunately, this is not the case for Aboriginal and Torres Strait Islander peoples, with on average, Indigenous women at a 4 times greater risk of experiencing maternal mortality and at a 2 times higher rate of neonatal preterm birth, low birth weight, and stillbirth. These rates are astronomical, and despite the Australian government's dedication to closing the 10-year life expectancy gap between Indigenous people and non-Indigenous Australians, small progress has been made in eliminating chronic diseases such as cardiovascular disease, diabetes, hypertension, and renal disease. These adulthood diseases have been strongly linked to beginning in genesis in utero and in early life, illuminating the paramount need for midwives to have a holistic and preventative approach to care, as opposed to a fixation on diagnosing and treating medical conditions. Midwives must have an understanding that Aboriginal and or Torres Strait Islander women and families continue to suffer the impact of racism, colonisation, and the stolen generations, which can result in a fear and distrust of government services and the hospital environment. Marriott et al. Debunked this concept in 2020 in their quality study, which illuminated that Australian midwives lack the cultural understanding and sensitivity required to fulfil Aboriginal women's cultural requirements. Indigenous women not having care tailored to meet their needs during the maternity period has led to women reporting high levels of dissatisfaction, creating the knock-on effect of poorer levels of engagement and mistrust towards the health provider. In addition, higher proportions of Indigenous women living in rural communities has led for them to have to relocate for birth to ensure a skillful birth attendant is present for labour and birth. This relocation in pregnancy leads to Aboriginal women birthing without support people, worrying about their children left behind, and suffering logistical and financial burdens related to travelling.
The Indigenous Maori people of this land were colonised by the British in the early 1800s, leading to a loss of land, resources, cultural identity identical to the experiences encountered by Australia's own Indigenous peoples. The Treaty of Waitangi was the founding constitutionalised document signed in 1840, which promised to promote and protect autonomy, equity, and comparative status of the Indigenous Maori peoples with the British citizens. There are many versions of this treaty, the Maori version being called Te Tiriti o Waitangi, which is nationally recognised as the most distinguished version, especially in regards to healthcare. All health legislation and policies are based on the principles, partnership, protection, and participation developed by the Royal Commission on Social Policy, from the articles stipulated in this version of the treaty. This version also provides the foundation for the ethics, standards, and professional competencies of midwives. During the 1900s, obstetrics controlled maternity care and education, which eliminated the contributions of midwives, which then began the political change to reclaim and advance New Zealand's maternity system. In 1990, the Nurses Amendment Act reinstated midwifery autonomy, creating a causal sequence of events that transformed their fragmented and medicalised maternity system to one focused on women and led by midwives, placing continuity of care at the forefront. This allowed for the same funding and resources provided to doctors to also be given to registered midwives. In addition to this amendment, another legislative act that promotes midwifery care is Section 88 of the Public Health and Disability Act 2000. Continuity of care is a core aspect of this legislation, leading to most women in New Zealand receiving continuity of care throughout their pregnancies, regardless of risk. This is led by the lead maternity carer, which is responsible for assessing needs, planning, providing, and coordinating maternity care from pregnancy and up until 6 weeks postpartum. The LMC is chosen by the woman, with over 78% choosing a midwife working within a community-based group, providing home-based and hospital care. In New Zealand, childbearing Maori women have a higher risk of poor outcomes, so they must be efficiently supported during their pregnancy journey. Many Indigenous women who then experience the Australian maternity system comment on the disappointing and inadequate services provided specifically surrounding continuity of care programs. In one study, a Samoan woman highlights the need for Australia to become more culturally sensitive and understanding, stating, "I think what's lacking here in Australia is a cultural awareness and sensitivity to the way that they structure their system, their health system. That's across the board, not just in pregnancy." The Ngā Mai is a Maori midwives collective that was formed in 1993, which works alongside Maori midwives and women to address inconsistencies in maternity systems. This collective became recognised as the voice for the Maori, and by 2008 its role was officially endorsed by the Midwifery Council of New Zealand and the New Zealand College of Midwives. Their mission was to support the retention and recruitment of the Maori midwifery workforce, promote and protect the tikanga values of traditional Maori birthing and parenting knowledge, and support Maori whānau to achieve an equitable, clinically and culturally safe birthing and motherly experience. In 2007, they established the Turanga Kaupapa, which was a cultural framework for maternity care. This was then endorsed by New Zealand College of Midwives and became a mandatory competency for midwives, providing them with appropriate education and training to provide culturally safe practice.
So the question remains, how can Australia learn from its neighbouring country on its treatment of First Nation people in the maternity system? The answer is loud and clear. Australia's maternity system desperately needs to be remodelled, with space for continuity of midwifery care for all Aboriginal and Torres Strait Islander women and their families. It is already apparent that continuity constitutes many health benefits, such as increased vaginal births and decreased requirement for epidural analgesia, forceps, or caesarean section birth. Inclusively, the research illustrates that women younger than 21, when receiving continuity of care, are less likely to experience preterm birth or have their baby admitted to a neonatal intensive care unit. This is beneficial for Indigenous women and their newborns, as it poses a solution to the high infant and maternal mortality and morbidity rates. One of the biggest contributors to these poor outcomes for Indigenous women is delayed or poorer access to antenatal care. This is where continuity of midwifery care is transformative, with the one-to-one support of a known midwife throughout the whole childbearing process, increasing a woman's sense of trust, familiarity, and comfort. Therefore, if an Indigenous woman was to know her midwife, she's more likely to want to attend appointments, creating more time for midwives to not only assess her well-being in pregnancy, but also promote health strategies that address aspects of the woman's physical, mental, and social health. One hospital in Australia that has taken on this approach to care is Westmead Hospital's Dragonfly caseload model of care. Commencing in late 2020, the Dragonfly midwives provide continuity of midwifery care to Aboriginal women. The midwives understand the importance of kinship, community, and culture, assisting with women participating in their care and feeling comfortable and respected in the process. Another aspect of New Zealand's care that should be implemented within Australia is the country's involvement of tribe leaders in the policymaking and care provided to women. This was successfully achieved in the South Metropolitan region of Perth, whereby the local midwifery group practice liaised with respected Aboriginal grandmothers from the community to assist in identifying pregnant women and provide assistance with transport to appointments and advocate on the important health matters. If a similar partnership was established between LHDs and local Indigenous elders, it would not only benefit Aboriginal women in the direct community, but more importantly, would assist the large number of Aboriginal women from rural New South Wales that are transferred to tertiary hospitals during pregnancy.
By providing chosen continuity of care to all childbearing women, New Zealand has provided autonomy, equity, and government protection to all women no matter their culture, risk level, or socio-economic status. This in itself is a profound achievement and is ahead of the maternity care provided within Australia. By looking at the dedication of our neighbours, we can aspire to grant our Indigenous peoples the same respect, equity, and safe maternity care. Thank you.